Tori, it's good to have you here. My name's Connie Edgar. I'm the Director of Public Health, and I oversee several programs. We have the Personal Care Provider Agency, the Options for Long-Term Care Agency, the Commodities or the CSFP program. We also oversee, we have some of the HCP children that we do case management on, and that stands for Handicapped Children's Program. We also do disease investigation, and I actually run a small cash clinic here to meet the needs of those who are uninsured or underinsured, and to make sure we have access to care. The Personal Care Provider Agency program is one where people go in and do basic homemaking and housekeeping type jobs to help people stay in their home so that they don't have to go into a nursing home or some sort of facility. And that's a very good program. It helps the elderly, the blind, the disabled all stay in their own homes. And oftentimes the one thing they need is just a little extra help. The Options for Long-Term Care Agency is a program designed to, it pretty much does referrals and make sure they go out and assess people's home situations and try to get programs in there so they can stay at home. It can be something as minor as just needing a lifeline to maybe needing somebody to go in, cook and clean, somebody have a nurse stop in and fill boxes and things like that. So it's kind of a referral agency to help people stay in their homes. The Commodities program is designed to give away food packages for healthy and nutritious meals for those people who are just, they don't have the income to buy the better food products. So we do food products to them, and for some that are homebound, we actually deliver those. The HCP program is designed to meet the needs for case management. It's hard to navigate the healthcare system, and so for those children with special needs, that program is designed to help them access and to organize and to get in to see the different specialty providers there are. We also have them, we had the HCP clinics up in Alamosa where some of the specialty providers come down here, and so they're not having to travel all the way to Denver Springs or wherever the specialty is. And then disease investigation, of course, whenever there's some sort of a contagious disease, and there are reportable diseases by the state, that goes into a program, and then we call and investigate just to make sure that the disease stays contained, that it's not spread to other people, or to find the source of where it's coming from. And then, of course, my clinic. Let me tell you a little about the clinic. This is a new clinic. It was opened in May 2012. And the clinic itself was to meet the needs of those people who are uninsured or underinsured. It came about because we were seeing a lot of, we provide some services like checking blood pressure and doing throat cultures, and for years as I was working here, we would have people come in and they say, well, I have to come in here because either they couldn't get in to see the physician, there was up to a 2 or 3 week delay, or they would say they couldn't afford it. And so what I wanted was just a basic, straightforward primary care services provided at an affordable price, and we charge $40 for the average visit. Well, the best way I can tell you is the infrastructure's here. We already have the building, we have the phones. I was able to find a free electronic medical record that allows me to do my charting, so I didn't have to come up with a whole record. The other part of it is I am the nurse practitioner and I wear more than one hat, so the $40 is what we can do if we don't bill insurances. Once we start billing insurances, it requires a whole new specialty for somebody to bill and access all of that. But if we keep it simple and I'm just providing basic primary health care and preventative health care, we can charge $40 a visit, and we need to make about $12,000 a year to break even, which we did last year, and this year we're well on our way to that.
What brings you here to the valley, and what, and specifically, like, you could tell the deep passion that you have for helping people of the valley, and basically what inspires you to help the people here?
Well, just to clarify, I always consider myself from the valley, even though I was born in California. My father was in the Air Force, but my grandmother and my grandfather, they all settled here, and they were some of the original Mormon pioneers that settled Manassa area. So what brings me here is family, and my passion for the valley is growing up here and seeing the people and loving the people of the valley. I think the San Luis Valley has a very unique culture. And I always joke that you can't live in the valley and not enjoy the culture here. And so I just like the culture. I've got family here, long, deep roots here. And so that's what brings me here. And then I married a local boy, so local man.
And specifically, I mean, I know we have deep roots here and traditions here in the valley, but we notice that healthcare is kind of far in between, the different communities here. Can you explain a little more in depth of, how it is coming from a low-income family coming to seek help?
Well, I've had the opportunity of being both low-income and now I'm average income family. I was a single mother raising a little boy. He was 5 months old when I got divorced, and I was working full-time. I didn't have good health insurance and he had none, and he was sick a lot, and every time I'd go to the doctor's office I really tried to keep up on my bills, but I knew it was at least $50 then, and he's 30 years old now. It was $50 every time I'd walk into the doctor's office, and I was bringing home around $800 a month, and so it was pretty pricey. And so I felt the pain of the cost of health care. Accessing it was difficult. He needed to have his tonsils out. That was the reason he was so sick all the time. Finally, I did get insurance and he was able to have those out, but I felt the pain of not being able to access care. I remember cutting my hand and going over and begging my mom, who is a nurse, to please just steri strip it so I don't have to go to the emergency room because I can't afford that. And so I think accessing health care oftentimes is limited by funds, by the number of providers we have, the type of insurance we have. And then we have other challenges here because our county is such a wide open space. Travel is difficult. So I've seen people who were so sick they couldn't leave their house and didn't want to call the ambulance. I think of a 90s, she just passed away this past year, but we had a little 94-year-old woman who somehow fell through every crack there was, had no health insurance, had a chunk of land that she rented out, and that was her income. She had no avenues for health care, and we started taking her on, and we were able to get some private pay people to go in and take care of her, and she was able to stay in her home and die in her home, which was her wishes. But she was one that had no health care. She did not qualify for any health care without having to sell the whole farm.
So you were talking about the culture here, that you really like the culture. Can you share with us some of your cultural traditions with you and your family, and what that kind of means to you?
Well, family is a lot of our cultural traditions, getting together as family. I think it is both for the Hispanic side and the Caucasian side. What we do is we get together as family and we eat a lot. I think what is really rich about the culture here is that Hispanic heritage. You can't live here and not be part of that. I grew up on chili and beans, and I grew up just enjoying all those things. And oftentimes when I'd go out of the valley, people would say, "Where are you from?" Because you have kind of a Spanish and Southern accent. And that's not true. I don't have one. But anyways, but it is part of the ingrained culture. You grow up here, and it's a love we have. Interesting, I always thought that green chili was a Hispanic culture, but I think it's more of an Indian culture. So we have that also mixed in. So, and I think part of the culture too is the self-sufficiency, which goes along with my religion. And I think we have some very self-sufficient and tough people that live here, and also some very caring and loving ones. I've seen during time of crisis where everybody comes together and they bolster up the person who's bowed down. And there is some connecting. It's not as good as it should be.
And then, one of the things that I guess is, I assume in the past there was a situation in which you had more local providers that studied and came back. It seems in some of the other interviews we've done that one of the trends is a lot of people get an education, then they leave the valley, but they don't come back. What do you think might attribute to that?
Because they get paid better outside of the valley. And because we have a high rate of Medicaid and Medicare, you're not going to make a lot of money. You can make decent, but you're not going to make quite a bit of money. And I think part of it, what I'd like to see is, I've often said if we would help them get through college, they'd probably come back and stay because they have family. What we get are people that come in, they get their loans written off because we're a healthcare provider shortage area and a medically underserved population. They get their loans paid off and then they're gone. And what we need is to invest in our own people that are from here so that when they get their education, they can come back and they can stay. For example, myself, if it wasn't for being able to take online classes and do my degrees online and get my clinicals here, I wouldn't have been able to finish out and get my doctorate. So it was very important to me that I could stay here and get my education. And also, I feel like I'm vested now because I was from here and people worked with me. I think if we would invest in our own people, we would do a lot better. Well, I did do my doctorate of nursing. I evaluated the people that came into my clinic, and a lot of them at the time did not have health insurance. What I'm seeing, and I don't have hard numbers, but what I'm seeing is more people have insurance, but they can't access the system. So they're willing to pay out of pocket to come see me rather than access the system. And then I have quite a few people who are disenchanted with what's going on in healthcare, and they come to see me because it's a simple, straightforward way of doing healthcare. And actually, I think it's pretty cost effective because I don't access all the different things. I can provide a better product for less money because I don't have to jump through all those, the referral systems, and I can do what I want to. And I try to keep it very clean. I look at trying to prescribe some of the old medicines that still work very well, the $4 formulary. I advocate for my patients. I'll call and say they need this x-ray, what can you do? And tell them that they can only pay cash or whatever. But the Affordable Care Act, I think people are getting more insurance, but I think they're not accessing health care as easily as they once were, just because we're in a shortage area. Well, let me just explain what happened. For years, we were taught that you had to treat pain, and that came from the Joint Commission on Health Care. I mean, I can remember working at the hospital, and we got written up because we didn't measure their pain on a scale of 1 to 10. We didn't provide enough narcotics to them. And so people grew up in this environment of you've got to provide all these prescription narcotics. And so then the result is we get addicted people. Now it's swung the other way because of all the abuse of prescription drugs. Now I think that providers are afraid to prescribe prescription drugs for pain. And so now we have undertreatment. And what happens oftentimes is you take a person who's addicted to prescription drugs and they will find illegal drugs to meet that need. And so I think you're seeing a big change. And the prescription drugs are, they're under scrutiny. Everybody knows that the narcotics, I write very, very, very few narcotics, and oftentimes they're not even, I don't even think I've prescribed a type 2 or 3. It's been the lower ones for cough syrup and things like that. I rarely provide anything. And that's because I fear that. And if you do have chronic pain, I send you to a specialist that can deal with that. I won't. Or I send you to get the problem taken care of. One of the things that's interesting is I've had people with back pain that I've been trying to get in to have some surgeries done. And there's a backlog of surgeries indeed for back pain, which should have probably been taken care of years ago. And they're just now getting them in there because no longer do they have their narcotic pain medications. So I think a couple of things have contributed to the overuse. Number one, growing up in healthcare in an environment where you had to adequately treat pain and they recommended you use narcotics, to now they're saying don't use narcotics. Number two, because of the lack of access to care and because people didn't have insurance, the underlying problem was not addressed, such as a back condition that needed it. Because of the overprescribing of narcotics, we have more people who are addicted, and we are feeling the pain of getting them off that addiction. And I think that there is a place for narcotic drug use, but I think we have to be very, very diligent in how we do that.
Do you think you could talk, I mean, it's very interesting to think of the different subgroups that are served in the Valley, and there are so many distinct cultures in the Valley, and there are language barriers and there are cultural barriers. Could you speak to some of these different groups that you see come through the door?
Oh, I've seen a lot of different ones. You have, I'll start with the old school Hispanics that just speak Spanish. Fortunately, I have enough staff that I have adequate, and I know a few of the words, but we have adequate translators. And a translator is only as good as their language ability. And so that's one thing you have to be very careful about in healthcare, is making sure you have adequate translator. And we're fortunate to have one person on staff that speaks Guatemalan and Spanish, and then we have several on staff that speak Spanish. So that's a big thing. Number two, you've got to understand the culture. Oftentimes, I think people in healthcare say it's my way or no way. But if you look at what's going on, alternative treatments, alternative medicine is huge nowadays. I try not to ever tell people that that's bad, but I do tell them I need to know about it so that we don't have interactions. The alternative medicine is almost all of our drugs came from herbs and things like that. So I try not to ever say that that's bad. I also try to work with them. And I think that we could be more complementary of Western and alternative and Eastern medicine, whatever medicine it is, just let me know so we can work together. Another interesting tidbit of culture of what I've seen, we have the Amish. And I'm really learning a lot from them, and they're interesting. And one thing I have found, they're very self-sufficient. They'll do absolutely everything they can for self-care. And when they call me, I'm a little concerned. I'll ask them, can it wait an hour or two? Because sometimes they wait till the very last minute to call. And they don't have health insurance. They don't believe in health insurance. They pull together as a culture and take care of their own. There's just so many unique and different ways of addressing healthcare. We have people that do everything from oils and colloidal silver clear down to they want a pill for everything. My goal was to take care of those who couldn't access care because of finances. And if you look at the statistics, the people that don't have insurance, they're not the very poor and they're not the very wealthy. They are the working people, those that have a job, but they can't afford that outrageous amount of money to get health insurance. Even with the Affordable Care Act, I have a lot of people who say, I just still can't afford it. I'll just take the hit, and they call me.
What is your favorite place in the Valley and why?
Oh, that's tough. I like the valley. I like the variety of the valley. I think my favorite place in the valley would be home. That's where my family is. I love the wide open spaces of the valley. I love the mountains. I love the sand dunes. I love going to Hooper. I love being in the garden. I think my favorite place, though, is home with my family. I love being a healthcare provider. And specifically, I love being a nurse. I think people will ask me why I didn't become a doctor. And I did become a doctor in nursing. But the reason I chose nursing over being a medical doctor is I think nursing comes from a more caring side, and a physician comes more from a scientific side, although we utilize both in both cultures. I think nursing grows up under caring, whereas doctors grow up under science. So
It always makes me laugh when you get the reduction of paperwork act on paper.
yeah.
It gives you 2 or 3 pages telling you about how they're going through the efforts to reduce paper.
And computers were supposed to reduce paper, but they haven't. We use more paper now than ever. So whatever we're doing isn't working well.
Any other follow-up questions?
I've talked to a couple of the new doctors that have come in, and they said that their reason for coming here is because they really wanted to build relationships with their patients. But then they end up getting frustrated and leave. Do you think that's one of the major reasons why they would leave? Is there something that can be done?
I'm not sure about their frustrations, but if you truly wanted to build a relationship with your patients, it would be more than just that office visit. You would want to be out in the community. You would want to work hard to be part of that community. I see a lot of them coming in and they look down their nose at the farmer who's taken the safety equipment off their machine and got their foot stuck in a belt. And they say, oh, well, you handled your equipment wrong, rather than saying, you're working hard, I can understand. I see a lot of them being judgmental about our culture, and they don't belong to the culture. And I think that's part of what I'm seeing is their frustration and ours, because they don't understand, and they're not willing to go beyond that extra bit. The other thing I see is they bring spouses in that don't do well here. If you think about what we have here, we don't have a lot of shopping. You need to be outdoorsy. You need to be outdoorsy in 40 below weather. And so I think that's more of it. I see them being more judgmental and not trying to fit in. The ones that stay try to fit in by being part of the community.